today's chapter. And today's chapter is going to be chapter 9, which is articulations. One of my favorites, okay? One of my favorites. It's not a very long chapter, so it's not going to be a very long review, but you've taken all this time to learn the different bones. All right, so this week you're going to be going over, all right, in lab, the appendicular skeleton. So you're going to learn, we've seen a few joints when we've talked about the axial skeleton, right? But now, we're going to now talk about how we classify the different functional aspects of the joint. So first, let's define what a joint is. More often than not, and I usually use the terminology articulation, okay? Because basically when we're discussing joints or articulations, it's basically where bones are going to contact one another. And it's not necessarily going to be just between bones. It could be between bones and cartilage. And we'll also see bones and teeth as another example. So for those of you that are going into the dental field, okay, you're going to see this. So it's important. So of course, the study of joints, we call that arthrology. Now, the important thing is when we're going to classify our joints, we're going to classify joints based on their structure and function. So another way that I could say that is I could say we're going to classify joints based on their anatomy, which is structure, and then their physiology, which is function. Okay, so let's start off by talking about the structural classes. And there's 3 types, right? Fibrous, cartilaginous, and synovial. So the fibrous, right, we're going to see in between the bones, right, the bones will be held together by a dense connective tissue. And we've seen that with our suture joints, okay? You also have our cartilaginous joints. Those are going to be bones that are going to be joined by cartilage. All right, so if you've gone over and completed the axial skeleton, you saw the intervertebral discs. Those are cartilaginous joints. And then finally, synovial are going to be joints in which the bones are held together by ligaments, which is a dense, regular connective tissue. It's a form of connective tissue proper. But what's important is there's a cavity in these joints, and it's filled with fluid. And so we're going to get into the discussion on the synovial joints. But those are your 3 structural classes: fibrous, cartilaginous, and synovial. So that's when we're classifying the joints based on structure or anatomy. Now, let's classify the joints based on function, their physiology. All right, so we have 3 types. We have our synarthroses, our ampharthroses, and diarthroses. So the first 2, we're going to not see a lot of movement going on. All right, the synarthroses are immobile joints, and we all know what that means. They don't move. So these joints are either going to be fibrous or cartilaginous. Ampharthroses, we have just a little bit of movement. Okay, again, these types of joints will be fibrous or cartilaginous. Our final type, the diarthroses, these are the freely mobile joints. This is easy to remember because all of these joints, these diarthritic joints, are synovial joints, which means they're joined by ligaments and they have a capsule, and in that capsule it's fluid filled. Okay, so diarthroses are freely mobile joints, and all of our diarthroses are synovial. So which brings me to an important concept here, because when you notice there how when I was discussing some of the functional classifications, you notice me saying that some joints are immobile, some joints are slightly mobile, and others are freely mobile. So that has to do with motion. So when we're talking about the range of motion of joints, there's an important concept that is really crucial for you to understand. All right, so when we're talking about the ranges of motion, right, and you saw on the previous slide how some joints don't move at all, whereas other joints are freely movable. So you notice that the range of motion is quite diverse and extensive. It goes from no movement to a lot of movement. All right, and basically how much mobility a joint is able to experience is highly dependent on the structure of the joint. Okay, so let me repeat that. All right, the amount of mobility and also stability, we'll talk about stability here in a moment, is highly dependent on the anatomy or the structure of the joint. So we'll see that there's this relationship, and this is a very important concept here. So you really want to highlight that and make sure that you understand this concept. Okay, it's another one of those inverse relationships, and we've seen inverse relationships before. In chapter 2, you saw it with the pH scale. The more acidic, right, that a solution was, the lower the pH level, or the lower the number, the value on the pH scale. So an acid is going to have a low pH, 1, 2, 3, okay, but it had a large concentration of free hydrogen ions or protons. Okay, so when we're talking about an inverse relationship, one value increases, the other one decreases. So here, when we're talking about mobility and stability for joints, simple. The more mobile a joint is, the less stable it is, and vice versa. The more stable a joint is, the less mobile. So we've studied the skull, and you saw that the sutures of the skull, okay, were very stable joints. Hardly any movement is going to occur at those areas there. Now let's swing it to a really mobile joint, your shoulder joint, called the glenohumeral joint. It is one of the most mobile joints in your body, but guess what? It's not very stable, right? It's much easier to dislocate your shoulder than it is to dislocate your left parietal bone on your right parietal bone. Okay, so keep that in mind. Inverse relationship between mobility and stability. And that's what this picture here is showing you, all right, with the different types of joints here, right? As we increase one value, right, as we increase the stability here, we're decreasing the mobility. Least stable, here's an example, our glenohumeral joint, very mobile. All right, so now let's go through and talk about the different types of joints. I promise you, I'll try to make this as interesting as possible. So let's start off with our fibrous joints. Okay, so fibrous joints, think we're going to be dealing with some sort of fibers. So we're going to be dealing with specifically dense, regular connective tissue. Okay, so we saw some examples of dense, regular connective tissue when we were studying chapter 5. All right, so dense, regular connective tissue is very strong. Lots of collagen fibers, very little ground substance. Okay, not a lot of vascularity. Some of the characteristics of that type of tissue. But these fibrous joints do not have a joint cavity. So they're virtually immobile, or they might have a little bit of mobility. So there's 3 types: gomphoses, sutures, which we've seen already, and syndesmoses. Well, the gomphoses, one of my favorite joints, all right, because it's a peg and a socket joint. We'll get into all these different joints here shortly. Okay, the next type of joint, the cartilaginous, so of course we know we're going to be dealing with cartilage, and the 2 popular types that we're going to be dealing with when it comes to joints are going to be hyaline and fibrocartilage. Again, we do not have a joint cavity. So again, these types of joints are not going to have any movement to very little movement. And so there's 2 types, called synchondroses or symphyses. And when I show these joints and where they're located, a lot of you will be like, oh, okay, yep, that makes sense. That makes sense. And then finally, our last type of joint here is going to be the synovial. All right, these are the diarthroses. They're freely movable. Okay, most of the joints in your body are going to be synovial joints. So that means that we'll have a joint cavity in between the bones that are articulating here. So with these types of joints, all right, you're going to have a joint capsule, also known as an articular capsule. And so we're going to also have a joint cavity, and that joint cavity is going to be filled with synovial fluid. And we'll talk about all of what synovial fluid here does here shortly. All right, then on the bones that articulate or that contact one another, okay, we're going to coat those ends of the bones with articular cartilage. And articular cartilage acts as a shock absorber, but importantly, it protects the ends of the bones. It helps to reduce friction. So now we got to tie all this stuff together. So we're going to hold our joints together through ligaments, but then also let's not forget, we need to nourish these joints. We have to provide it with nutrients and get rid of waste. So guess what? We're going to have lots of blood vessels, and then we need to have a tissue that's going to tell these joints what to do. And so we're going to have nervous tissue, because we need our nerves to sense movement and also tell certain tissues, i.e. muscle tissue, when to create movement. So here's a nice picture of our synovial joint here. Okay, so you can see, all right, we have two long bones, all right, and you have, all right, a capsule around the long bones. We'll talk about it. Our articular capsule is made up of two layers, an outer fibrous layer, okay, similar to like a periosteum. We had two layers there. The outer layer was made up of that dense connective tissue, okay, that adds stability to the joint and protection. And then we have an inner layer here, that's the synovial membrane. We'll talk about that. I'll get into all that. Okay, so then we also have our joint cavity here filled with the synovial fluid. And then coating the ends here of the bones is going to be our articular cartilage, which is hyaline cartilage. So that protects the ends here from grinding down on top of one another. Then we hold it all together with ligaments, nice dense regular connective tissue, okay, that adds more stability to the joint. It's wonderful stuff. All right, so let's talk about our synovial tissue. All right, so the capsule that we're going to see that surrounds these joints, these synovial joints, we call that the articular capsule. So it's made up of two layers. Okay, the outer layer is going to be that nice, tough, strong, dense connective tissue. Lots of collagen fibers are going to be present there. Okay, so again, that's going to add a lot of strength to the joint, prevents dislocations. The inner layer is made up of areolar connective tissue. It's a loose connective tissue, but it's this layer that is going to produce that synovial fluid. And keep in mind, we will see the synovial membrane, right? You can see it here, okay? It's represented by this purple color, okay? That is the synovial membrane. But notice the synovial membrane is going to be in areas where we don't see articular cartilage. Take a closer look. I'll zoom in for you. Notice you don't see that synovial membrane anywhere where there's articular cartilage. Well, think about it. Again, you don't have to be a physiologist or anatomist to understand that. It would be foolish for there to be synovial membrane where there's articular cartilage, because what's the purpose of the articular cartilage? It's to protect the bones, yes, but to reduce friction. So basically, where there's articular cartilage, that's where the bones are moving. They'll be sliding past each other. So it would be very bad to have synovial membrane in areas where the bones are moving on top of one another, because you could damage that tissue. So it makes sense not to have any synovial membrane where there is going to be articular cartilage. So you don't have to be a scientist to know that. All right, so we've talked about articular cartilage, or you've read about it and learned about it in chapter 7. Okay, we saw that it's going to be on the surface of the joint here, and its job is to reduce friction, act as shock absorption, and by doing so, it helps to prevent any damage to the ends of the bone that are involved in the joint. Also, as we've learned before in chapter 5, mature cartilage is avascular. Mature cartilage is avascular. Articular cartilage is no different, okay? But also, it does not lack, it does lack perichondrium. If you recall, perichondrium, okay, is that tissue that sits on the outside of some cartilage. It's not on fibrocartilage, okay, but it is on hyaline cartilage and our elastic cartilage. Okay, but on articular cartilage, it is not going to be present. Okay, so keep that in mind. It's no longer there. All right, so continuing on with the synovial joints here, we have a joint cavity. That's that space that's found between the bones. And so this is where we're going to find our synovial fluid. I love synovial fluid. It's like motor oil, okay? What do we need motor oil for? Right? When the pistons are moving inside the engine block, all right, the motor oil helps to reduce friction. Well, so does synovial fluid. It's viscous, similar to that motor oil. And so it adds for lubrication on the joint surfaces. Now, articular cartilage is already very smooth, very glassy in appearance. So it's already reduced the friction quite a bit. If you've taken physics, they call it the friction coefficient. Okay. And so some things you want to have friction, like for example, your tires on your car. When you were driving on the road, you were very grateful to have friction going on. Otherwise, you'd slide off the road, especially in the wintertime when there's snow on the road and when it's raining outside. Okay. But in this scenario, you don't want to have friction, or you want to have as minimal amount of friction as possible. Because simple thing, rub your hands together really fast and really hard. What happens? Your hands start to warm up. That's due to friction. And so that can occur if there's friction going on in the joint. So it's going to help lubricate the joint to help protect the bones there. And so the nice thing too about synovial fluid, remember what we said, all right, the articular cartilage is avascular. So it needs a way to get nutrients. Well, synovial fluid does just that. It helps to nourish and it helps to remove any of the wastes, all right, from the articular cartilage. And let's just throw in an added bonus feature, helps to absorb shock. Okay, so you have all these things here in your joints, all right, that help to protect the joint. Okay, because, well, I mean, we really want these joints to last literally a lifetime. Okay, so when we're talking about the synovial joints, okay, we're going to discuss, all right, the different types of movement in our synovial joints. And it really is based on, all right, the shape of the joint. So we have a couple different classifications of movement. All right, so you have a uniaxial joint. It's when a bone moves in just one plane, okay, like a gliding motion, for example, okay, or a rotational movement around an axis. We have a biaxial, bi meaning two. So we'll have these joints moving in two or more planes, or two or more, or two axes, excuse me, I shouldn't say two or more, it's just two planes or axes. Then our multi-axial, okay, in which these joints, all right, the bones move in many planes and or axes. Okay, so let's break it down and talk about, all right, the mobility of these joints. We have plane joints, hinge joints, pivot joints, condylar joints, saddle joints, and ball and socket joints. As we move down our page here, we go from least mobile to the most mobile. So the plane joint is going to be the least mobile. The ball and socket joint is going to be the most mobile. Let's start off with our plane joint. All right, so these here, all right, are going to be our articular surfaces, all right, are basically going to be flat. And they'll move through a side-to-side gliding movement in a single plane. So you'll see that in your carpal bones in your wrist. So if you haven't started to learn about that this week, you will. Okay, the carpal bones are short bones, which means those bones are relatively as wide as they are long. And so you have two rows of them. I won't get into the details. You'll see that later on when you're going over the appendicular skeleton, but they slide and glide past one another. All right, the next joint you are very familiar with, the hinge joint. Okay, so one of the bones is going to contribute a convex surface, which is this rounded surface. And then the other bone is going to give a concave. Okay, so it will be kind of like a depression there. So like you've seen hinges on a door, okay? Some of the examples for a hinge joint are your elbow joint, okay? Your knee joint can act like a hinge joint. The pivot joint, we're going to see how the bone is going to have, again, a rounded surface, and it'll rotate, all right, when we're talking about the uniaxial joint, it will rotate along the longitudinal axis. So when you were studying the axial skeleton and you were going over the vertebral column, we learned about, okay, some of the typical vertebrae in your spine, but we also learned about two atypical vertebrae, C1, which is the atlas, and C2, which is the axis. And C1 will pivot around the dens or the odontoid process of C2. And so basically when you're shaking your head no, going from side to side, okay, that is a pivot joint of C1 on C2. Our next type of joint is a condylar joint, right? These are oval here, okay? And so similar to what we saw just a moment ago, you have a convex surface that's articulating with a concave surface, but this can move in two axes, not just one, but two. Saddle joint, again, we'll see another convex and concave surface. Biaxial movement here, all right, your thumb joint is a perfect example of a saddle joint. And then finally, one of the coolest ones is the ball and socket joint. So literally, all right, one bone is going to have this big rounded structure here, and it's going to sit in this cup-like structure. And these type of joints move in several different planes, right? They're the most freely movable type of joint, ball and socket. Your hip joint is an example of that, and your glenohumeral shoulder joint is another example of the ball and socket joint. Okay, so our gliding motion, we are going to see two surfaces relatively flat are going to move back and forth or side to side. Okay, that's going to create, all right, limited movement. And so we'll see this in your wrists, the carpal bones, and then also your tarsal bones, which are the bones that make up the majority of your foot. Again, it's because these joints will slide back and forth on one another. The other type of movement, and we're going to spend more time talking about, is the angular motion movement. Okay, so you saw here we had the gliding movement, okay, either back and forth or side to side. All right, very limited amount of movement that we can see. All right, and then we have our angular motion. So this is where you're going to hear those terms like flexion extension, circumduction, all right, lateral flexion. So we're going to go through these different types of movement here to kind of give you an idea, right, or a better understanding of that motion that occurs. So when we're dealing with angular motion, we're going to be dealing with the angles that are created between the two bones. It's real simple. Angular motion is either going to increase the angle or decrease the angle. All right, it's taking you back to a little bit of geometry there. So the first one is flexion. And so when we're dealing with flexion, you have to know which plane that we're dealing with. We're going to be dealing with the anterior posterior plane. So basically front to back. All right, so when we're talking about flexion, we're going to decrease the angle between the bones, which means we're going to bring the bones closer together. So when you flex your elbow, as you're bringing a cup up to your mouth to drink, you flex your elbow. That is flexion. Okay, when you're clenching your hand into a fist, you are flexing your fingers. Right? Extension, okay, is the opposite. We're still going to be in the anterior posterior plane, the front to back, right? But now we're going to increase the angle between the two bones. So after making that fist, okay, now you're going to open it up because you're going to go shake somebody's hand. So when you go to shake somebody's hand, which isn't something we do very much anymore with COVID, but when you go to shake somebody's hand, you extend your fingers out. All right? Or after you're done drinking and you want to set the cup down, you're going to extend your elbow. You're going to open up your elbow joint there. All right. So now there's another term here called hyperextension. Now, for those of you that have had some experience in sports or just any type of motion activity, okay, there's a term called hyperextension. And I don't want to confuse that with what actual hyperextension is, okay? Because you can have a hyperextended injury in which you've extended your knee too much. But basically, it kind of relates to this a little bit. This is what happens when we extend a joint more than 180 degrees. Now, in most cases, all right, a lot of the joints, except for some of the ball and socket joints, will not extend past 180 degrees. So if we're looking at angles here, this is my best attempt at a right angle, that's 90 degrees. Okay, that's if you bend your elbow. And then you have 180 degrees, which is this. All right, that's 180 degree motion with the pivot point right here. All right, now what happens when we extend it too far? You may have done that to your elbow once or twice, or to your knee. That's the hyperextension. All right, so an example would be, I always have patients look up towards the ceiling. Okay, and I'll show you hyperextension with a picture here to give you a better understanding. But literally, if you're standing there and you look up towards the ceiling, all right, you're in a real nice museum or you're going to a church or something that's going to prompt you to look up towards the ceiling, maybe the planetarium, okay? That is hyperextension of your head and neck. Then we have lateral flexion. So lateral flexion is when we're going to move through the coronal plane. What's the coronal plane? The coronal plane, going back to chapter 1, is the plane that it's going to divide your body into anterior and posterior sections. All right. So with lateral flexion, we're going to move through that coronal plane, okay, laterally. So perfect example is what happens with your spine in the cervical and lumbar region. Okay, so for example, you're looking straight ahead. I tell you, hey, move your right ear as close to your right shoulder as possible. So then as you tilt your head to the right and you're trying to touch your right ear onto your shoulder, that's lateral flexion. All right, or if I say, all right, stand straight up, put your hands to your side. All right, now what I want you to do is, all right, just slide your right hand down your leg as close to the knee as possible. And as you start to lean to the side there towards the right, you are undergoing right lateral flexion. So let's take a look at some of these motions here. Pictures always help. Okay, so you can see here in our first picture, okay, this gentleman's looking straight ahead. You tell that person, all right, touch your chin to your chest. They are flexing, okay, their head and neck. Then you say, okay, look straight ahead again. And they go from touching their chin towards their chest back to looking straight ahead again. That's extension. Then when you tell them to look back towards the ceiling, that is hyperextension. We're talking about at the elbow here, okay? Tell them to make a fist, all right? Bring your fist toward your face at the elbow. You start to flex your elbow. All right, straighten your arm as far out as you can. Then you're extending the elbow. Okay, it's all about the angle between these bones here and this bone here. Okay, same thing here with the wrist. Okay, put your hand straight out. Okay, now flex your wrist. Okay, bam, bringing your wrist forward. That's flexion. Returning it back to the extended period straight out. That's extension. Hyperextension is bending it all the way back. So you can see these examples. Same thing here with the knee. Here's the lateral flexion. This lady is doing left lateral flexion. She's bending her trunk. Okay, she's moving through the coronal plane here. She's bending her trunk to the left. So these two terms here might be new to you. AB or abduction and adduction. Sometimes you'll hear me say abduction and adduction. So there's no mistake as to what I'm saying. So if you've ever been kidnapped, you've been abducted. Okay, so what happens when you're kidnapped? You're usually taken away from your home or from work or wherever. Okay, so when you're abducting something, you are going to be moving a body part away from something else. So in this scenario, we're talking about lateral movement of a body part, could be your arm, could be your trunk, could be whatever, okay, away from the midline. Okay, so really we have to define what the midline is because it varies depending on where the abduction is occurring. All right, so for example, when we're talking about the arm or the thigh, okay, the midline is going to be your axial skeleton, or let's just make it real specific, your vertebral column, your spine. So if I'm standing there in the anatomical position, okay, and I start to raise my hand away from my body, okay, you tell me, hey, put your arms out to your sides. And so as I raise my arms away from my body, I am moving my arms away from the midline. That's AB abduction. Same thing if you tell me to bring my leg away from my other leg. Okay, I'm moving my thigh laterally away from the body midline. Adduction. Well, when you add something to something else, right, you're bringing it towards something. So adduction is going to be medial movements of a body part toward the midline. Same thing with arms or legs. If you have your arms out to the side, okay, and I say, okay, bring your arms back towards your side. So now when you lower your arm back against your body, all right, you're moving it toward the midline there. So here you can see, here's a perfect example. Here's our lady on the left, okay? She has her arm against her side. She raises it away. That's abduction. She's moving it away from her midline here. Then when we say, okay, ma'am, go ahead and lower your arm, bring it back against your side. She's adding it. She's adducting, adding it to the midline. So when we talk about abduction and adduction for the wrist, okay, again, you're in the anatomical position. If you bend your wrist towards your body, okay, you're adducting it. If you bend it away, you're abducting it. Here it is for the hip, okay? Lady is moving her leg. She's doing some leg kicks, all right, warming up for a dance recital. So when she brings her legs away from her, when she brings her one leg away from the other leg, away from the midline of the body, that's abduction. And then when she returns it to the center, that's adduction. Now, when you see here at the fingers, our midline is going to be the middle finger here, okay, your third digit. That is our reference point, our midline. So when you open your fingers up and spread them out, you're moving your other digits away from the third finger. That's AB abduction. Then when you bring your fingers back towards your third finger, that's adduction. Okay. So in this scenario, our midline is going to be the middle finger. All right, circumduction. Okay, circumduction involves a circular motion. So when we're dealing with circumduction, all right, one part of that joint, all right, the proximal end is going to be almost like our anchor point. Okay, so that area, all right, or region is going to be somewhat stationary. Meanwhile, the distal end, the far away end, is going to be making that circular motion. So you can see in the drawings here, or when we're discussing circumduction, okay, arm circles. You probably did it in PE class at one point or another to loosen up. So when you were doing that and swinging your arms into a circular motion, all right, what we see here, okay, at the glenohumeral joint, all right, that area is relatively stationary. Not a lot of movement occurs there compared to over here. And the same thing with the hip joint. But we're making a cone-like shape, like a megaphone, all right, when we're making those motions occur. All right, so that's angular motion. What about rotational motion? So we have gliding motion, we have angular motion. Now we're going to talk about rotational motion. This is when, all right, the bones are going to pivot around a longitudinal axis. Okay, so if you look here, there's a couple different terms: lateral rotation, medial rotation, pronation, and supination. So I'm going to go through and explain those motions with you. All right, so lateral and medial rotation is going to determine, all right, when the bone is moving, right, and we're going to see the anterior surface of the bone. So that's our reference point, is the anterior surface of the bone. So we're always going to base it on the anatomical position. So remember the anatomical position. Okay, feet are stationary, flat on the floor, and toes are pointing forward. Arms are down to your sides, your palms are facing forward. That is going to be the anterior surface. And so when we undergo lateral rotation, the anterior surface of that bone is going to go laterally, face out. For medial rotation, the anterior surface is going to face in or rotate medially. I'll show you pictures. Okay. Pronation and supination has to do with the forearm. Okay. So when we talk about pronation, we're referring to, all right, medial rotation of the forearm that is going to cause the palm of your hand to face posteriorly. Supination is the opposite. Okay. We're going to undergo lateral rotation of the forearm, so the palm of the hand is going to go anteriorly. So a way that I remembered it is, if you take both of your hands and put them next to each other, and you cup your hands, right, like if you're going to drink water. Say you've been in the desert for 4 days, you haven't drank any water, you're severely dehydrated, you come across this oasis spring. What's the first thing you do? You cup your hands together to make like a bowl, and you start scooping water into your mouth, gulping it down. Okay. Well, how I remembered that is when you put your hands in that position, okay, it's like drinking soup. Okay, so that's how I remembered it. Supination, soup, you're cupping your hands, all right, your palms are facing anteriorly. And that's causing lateral rotation of the forearm. Pronation is the opposite. Okay, so you go into that supinated position, all you're going to do is now turn your palms of your hands in the opposite direction, turn them down. And that's going to be moving the palms posteriorly. I'll show you in case you're having a hard time following, no problem. All right, so rotational movements here, you can see our lady on the left, right? She's doing her best at the Linda Blair exorcist, shaking her head back and forth, okay? That is going to be rotation, turning your head and neck from side to side. Here, if you bend your elbow at 90 degrees, okay, and you keep your hand, all right, upward in that position, if you turn your hand outwards, that's lateral rotation. If you bring your arm across your body, that's medial rotation. You're bringing it inwards. Same thing here with the leg, okay? If you twist your foot outwards, that's lateral rotation, because remember, right, the anterior surface of the bone here, your shin bone, is now facing laterally. Now, if you turn your foot inwards, your shin will be facing inwards. That's medial rotation. All right, pronation and supination. Here, I'll start with supination. The palm is facing forward. Okay, so if you bring both your hands together, it's like drinking soup. Okay, now all I'm going to do is turn my hand back, so the palm is facing posteriorly. That's going to be pronation. All right, let's finish up with some special movements here, and then we'll call it a day. All right, so these special movements, all right, don't fit into those other categories. So we have depression and elevation. Okay, depression, you're going to actually drop the body part down in an inferior movement. Okay, opening your mouth. Okay, if you go to shrug your shoulders upwards and then you drop your shoulders back down, that's depression. Elevation, when you close your mouth. Okay, like when you're chewing, every time your teeth come together to mash on something, that's elevation. Or if you shrug your shoulders up towards your ears, that's also elevation. You're going to be moving that body part superiorly. Here you can see this gentleman, okay, shrugging his shoulders upwards. That's elevation. When he drops them back down, okay, that's depression. All right, dorsiflexion and plantar flexion. You're only going to use these terms when we're talking about the ankle joint. Another name for the ankle joint is the talocrural joint. And so essentially, again, we're going to be in the anatomical position when we start this off. When you bring the dorsum of your foot, that's the top of your foot, towards your shin, okay, or your leg, that is dorsiflexion. Another way is if you've ever been asked to walk on your heels, okay, when you're trying to walk on your heels, you're going to try to raise the dorsum or the top of your foot toward your shin. All right, plantar flexion is the opposite. All right, if you're going to jump off, all right, to do a layup for basketball, right, you are going to plant your foot. So plantar flexion, right, what happens is the dorsum or the top of your foot gets pointed inferiorly. Okay, you've seen this all the time before, probably with ballerinas. Okay, when they go onto their tiptoes, that's plantar flexion. So you can look over here. Okay, here's the top of your foot. We're going to try to bring the top of your foot as close to your shin as possible. So when we do that, that's dorsiflexion. So we're raising our toes up towards your shin. Then when we go to point your toes down towards the floor, that's plantar flexion. Eversion and inversion. All right, so when we're talking about this, again, we're going to be dealing with the foot. All right, so when we're talking about eversion, the sole of your foot, that's going to be our reference point, is going to be turning outwards or laterally, which is tough to do. Eversion is not an easy motion or movement to do. Okay, inversion, now we're going to take the sole of your foot and turn it medially or turn it in. This is the most common type of ankle sprain, by the way, is an inversion sprain. When people say, oh, I rolled my ankle, that's what they're doing. They're inverting their foot too much, and then to the point where it's caused damage to the ligaments there. So that's inversion. Protraction and retraction, right? Again, we are going to use the temporal mandibular joint for this, okay? When you have your jaw, all right, moving anteriorly or jutting forward, that's protraction, okay? When you pull it back, all right, in a posterior direction, that's retraction, okay? So if you've ever seen Gilligan's Island, okay, Mr. Howell, all right, he protracted his chin all the time, kind of talking like this, all right, sticking his jaw forward, okay? Retraction is just pulling your jaw back posteriorly. And finally, let's throw in a couple of our what we call arthrotides, different types of conditions that you get. A lot of you have probably heard of the big A, the arthritis, okay? Important that you understand arthritis is a group of inflammatory degenerative diseases. So it does require inflammation. When you have inflammation, you cause joint damage. And what does joint damage eventually do? It causes degeneration of the joints. Okay, so if you have inflammation, you're going to have swelling. And then you'll also have pain and stiffness. So gouty arthritis, also known as just gout, right? These folks suffer from a significantly increased amount of uric acid. For whatever reason, their body can't clear the uric acid, all right? And so what will happen is these crystals will precipitate out into the joint spaces. For those of you that have ever had gout, it's very painful. So remember what I was saying. We want very little friction in these joints. Well, guess what? Gout doesn't do that. These uric acid crystals precipitate out, and now you have these crystals floating around in the joints, all right, causing, all right, friction and pain and damage. So we'll see it mainly in men, okay, in their middle ages, okay, so usually in their 4th, 5th decade of life. Gout can be prevented. You just have to decrease anything that's going to increase your uric acid levels. So you got to reduce food, like preservative food, like deli meats, anything that could possibly dehydrate you. So I hate to say it, you got to cut out caffeine, stop drinking sodas. All right, stay away from sweet tea, coffee, all that fun stuff. If you can do that and make sure that you're pretty hydrated, then your gout attacks will be very, very infrequent. Osteoarthritis. This one is commonly known as just arthritis, okay? But osteoarthritis is what happens in folks as they age, all right? The joints start to degenerate, all right, for a number of reasons, but primarily because we wore down the articular cartilage there. And then once the articular cartilage is worn away and gone, then the bones start to suffer because now they're exposed. And so we'll start to get degeneration in those joints there. So we're going to see it in areas that undergo a lot of movement. So fingers, especially the knuckles, hips and knees all the time. And then finally, we have rheumatoid arthritis. Okay, rheumatoid arthritis is an autoimmune. And so if you hear that there's a certain condition, disease, what have you, that is autoimmune, that means it's going to most often affect women much more than men. Okay, just how it is. Just how it is. But what will happen is, all right, you'll get the synovial membrane becomes inflamed, and it creates this thing that's called the pannus. And it's this inflamed synovial membrane that causes significant pain, reduction in range of motion. So these are some of the more common types of arthritis that we do see in individuals. All right, so that is the end. I told you that that chapter is a relatively short chapter.